Hello, this is Dr. Praveen Chandra from Medanta Medicity Hospital in New Delhi, India, and I'm here at the EuroPCR 2023. And along with me is my friend Dr. Dilip from Medica Heart Institute from Kolkata, again from India. So today we are going to discuss the issues and the nuances of treating ST elevation MI, especially in the perspective of choosing a stent and use of ultra-thin strut stents in treatment of primary angioplasty or primary STEMI treatment in these patients. So, welcome Dr. Dilip, and we are going to have a free-flowing discussion, and let's make it worthwhile for everybody to understand. So, first of all, what do you think are the new changes which are happening in the treatment of ST elevation MI and ACS?
Thanks for having me here. And STEMI is a ever-evolving branch of cardiovascular medicine. And we have seen some interesting changes and developments in the last 1 decade. So starting from rapid revascularization, every society, every country is working on hub and spoke pattern, how to decrease the chance, reduce the chances and delay of coronary reperfusion. Second, there is a more and more focus on optimizing antithrombotic, the anti-platelets which we choose. Third, on safety parameters, more and more centers are adopting radial route of intervention, which is very, very useful in especially in STEMI, and that has drastically reduced the vascular complications. And finally, there are some disruptive hypotheses are also coming up, like large interval MI, putting them first on mechanical circulatory support. After half an hour, do revascularization. This kind of animal model, some work has been done. So these are real good developments happening on STEMI front.
Yeah. So the issues are that we get the patient as fast as possible, which is number one. And in India particularly, there is an issue in that because the healthcare system is not very jointed. It is a little bit disjointed, but still efforts have to be done to educate people to come to the hospital as fast as possible, either by themselves or with their relatives, because about 50% times patients come to the hospital with some relative, not in an ambulance, and 50% times only, or maybe less, they come in an ambulance. So this is somewhat different from the situation which exists in the Western world. So that is something which is there, which makes a difference in terms of overall final outcomes, number one. And number two is that they come from distant places also.
Yeah.
Because, and that is why we have to be very sure, when we treat these patients, they have to go back in their community, and that whatever treatment we do is long-lasting, easy to handle, not very complex, and we don't want to, we cannot follow these patients very easily because they are very far away, they are not contactable sometimes. So we have to provide a treatment which is like one stop and also does not need too much maintenance, which means the duration of anti-platelet therapy is one of the issues here. So let's go on to that, and basically let's discuss about what kind of anti-platelet therapy, the shortness of anti-platelet therapy you have in mind, and based on that, how do you choose your strategy of treating these patients?
Yeah. So I think it's very interesting, and the points you just discussed is really worthy of discussion from Indian perspective. So we see patients who have delayed presentation, coming from far from areas, and compliance is a challenge. So we need a regimen where we have to somehow cut down the antiplatelet therapy, dual antiplatelet especially. And when we use some devices which can be useful in curtailing that. So we have evidence now, especially with thinner strut stents, especially ultra-thin strut stents, which has shown promise with lesser TLR, and also the healing process is very rapid. And even if the NIH is there, it's a very thin layers, 50 micrometer average. It was shown in one trial, OCT trial with supraflex screws, that they get a 4 to 6 weeks, 50 micrometer thickness NIH. So that's really very comforting. And if we look at regimens, we have now pouring evidence with newer antiplatelets like reversible antiplatelets, especially ticagrelor, After 3 months, we have evidence. After 3 months, we can definitely, especially those patients who are high HBR, or if we have treated these patients, STEMI patients with especially ultra thin stents, we have more confidence in stopping dual antiplatelets if we feel any challenge with compliance or any HBR characteristics are there.
Right. So you have now very quickly opened the chapter of choosing the right stent for the STEMI patient. Which is the right stent? So basically now we are talking of ultra thin stents. So the data is there. The meta-analysis showed that ultra thin stent is better than the normal thickness stent, and also from the TALENT study, which was done comparing Zynes, it showed that in those patients who had acute MI, ultra thin was better than the Zynes stents. So which means ultra thin is showing a positive trend towards a better outcome in patients when they are being treated for ST elevation, myocardial infarction or acute coronary syndrome, because of reasons like they have less injury to the vessel wall, they have faster healing, and also one very important factor which I would like to point out right now is that many of these patients who are having ST elevation MI, when we open the vessel looks like a 3 millimeter vessel, and you put a 3 millimeter stent and suddenly you start seeing that the vessel is growing. Then what to do? Because the thicker stent struts can only go up to 0.5 millimeter mostly, or 0.75 extra. In thin strut stents with a Z link, which is there in the cruise, what happens is that a 3 millimeter stent can go up to 4.5, or a 3.5 millimeter stent can go up to 5.5 or 6 millimeters. Which means, and also sometimes we have to extend the stent from the LAD into the left main, because Indian patients have diffuse coronary artery disease, they have extensive disease, and sometimes we have to extend the stent from LCX to the left main. In those situations, I think ultra thin stent with a Z link, which can give a good expansion, is a great idea to start with, because then it becomes like a one stent for all kind of situation.
Absolutely.
And of course, in the long run, as you already said, that since the healing happens faster in these patients, the duration of anti-platelet therapy may not need to be like 2 years or 1 year or something like that. Yeah.
And and besides TALENT trial, we have meta-analysis also. 2 meta-analyses have been published, one by Bangalore et al., and where they have clearly shown, irrespective of the type of the stent, all across ultra thin struts, there is a reduction in TLF, and especially in STEMI patients. So I think it's very important to go in and quickly come out in STEMI patient. Number one, causing less trauma, get a better healing, a lesser chance of unwanted. We don't want to go for a long dual antiplatelets in our Indian patients. So rightly pointed out by you, sir. These stents can be very useful in future.
Okay, so which means that you are saying that this stent, particularly the cruise or the thin strut stents, should be the default strategy in patients who are being treated with ST elevation MI, and probably, since I am not doing primary angioplasties, my associates are doing it, and in the middle of the night they call me and say, okay, which stent to choose. Sometimes they are in a confusion. I tell them choose this one, because this is a one-stop solution for all the problems at the short term, on the table, and also in the long run. So that works out quite well.
And one more point I would like to add is the ease of delivery.
Yes.
This stent has proven beyond doubt that it has got a very, very low profile, and it is deliverable. Even if operator is a new operator, he can do easily. So
yeah.
I think it is right.
So your colleagues who are junior to you, or who are in the doing these primary PCI calls, they are generally fellows or senior fellows, and these people can easily hang on to this ultra thin strut device for these patients. So that is, I think, becoming reasonably clear that this becomes a easier, simpler, and safer solution. Then the second point, which we can briefly touch, is about the multi-vessel patients, because we have many multi-vessel patients in India, and also anywhere and everywhere else in the world. But in India, we have more diffuse disease, more complex disease. So these patients, you would go for a complete revascularization, or because it's acute MI situation, or you go for a selective revascularization.
So I think this has been haunting we all interventional cardiologists for long, and we have now evidence that we have to go for a complete revascularization in non-cardiogenic shock patients. But when to do entire complete revascularization? This is the question, and it depends mostly on patient substrate, type of lesions, and the operator, what operator feels. Suppose the patient has intravalvular MI or infravalvular MI rather with the OM branch occluded. If I open this obtuse marginal and I see a mid-LAD discrete lesion, I will go right then and there. But if I get a LAD ostial disease 100%, I open this and I have a RCA ostial 95% disease, some type C lesion, I will definitely not go on that setting. I will take a 2 days time, 48 hours, or sometimes maybe we can stage it for 2-3 weeks later. So we have to do complete revascularization. That is 100% clear with all the evidences, but when to do it depends on patient subset and the operator's preference.
Yeah, excellent. So we have discussed that complete revascularization is a good idea, but how to safely do it, that is the question, and how do we manage the logistic part of it? And here it is a very important angle which I am going to put, that in our country, in India, there are several social issues also. That the patient cannot come again and again because they come from far away. Number two, that the cost, if they come 2 times or 3 times admission to the hospital, there will be very high cost. And generally, if it is done in the same hospitalization, same index hospitalization, the cost is still limited because generally we charge for this one procedure or something like that. So for our country, for in India and for those countries where financial issues are definite, it's everywhere. But for us, it is there very important because most of the patients pay from their own pockets, maybe 60-70%. So that is why there has been a very big trend that these patients are treated in the same hospitalization, not at the same time. Maybe 48 hours later, 72 hours later, depending upon their clinical situation. Compared to Europe, where patients are discharged and then they are brought back because there are issues, because the hospital will probably be better off if they are done in 2 hospitalizations or 3 hospitalizations. So that is the difference which we see, and probably it is very handy that the data is also not favoring either of the strategies, so we can adapt it to our local situations.
I think for us, before discharge, maybe the right approach.
Yes. So that is where we are, and so basically to just wrap it up, we have really now these ultra thin strut stents, which are one-stop solution for the ST elevation MI patients, both in terms of deliverability. On the table, you can expand it to higher limits of the size, because this is a very common problem of the sizing of the stent in acute MI. And then the third is, of course, long DAPT therapy, which is not so much required here because the healing is much faster. So I think, thank you very much, and we had a great discussion. Hope it is beneficial for everybody to listen. Thank you.
Thank you.